So of all of us in the room, how many do intrathecal therapy? How many perform intrathecal therapy? That is amazing. It's really good. With the pain task force, the way that it is, that was one of the charges that we had highlighted at the NANS Advocacy and Policy Committee, was looking at the pain task force, and one of them was to limit systemic opiate use. And I want to be really clear when I say that I do think that intrathecal opiates work. And when you do them in the appropriate fashion, and when you use these pharmacokinetics and pharmacodynamic principles and understanding CSF flow as best as we possibly can, it does work. And we're going to go through some slides today that I don't think have changed significantly in terms of the understanding of the CSF flow dynamics since Christopher Bernard's and Tony Yaksh has done a lot of work in this. But it's still amazing to me sometimes when we go out and we talk to folks about intrathecal therapy and where to place the catheter and marrying the medication with the catheter location. And then not only that, but this new concept of using kinetics to your advantage is really critical. And so of us in the room that do intrathecal therapy, how many do bolus therapies? And between the continuous infusion portion of it versus the bolus portion of the 24-hour dose exposure to patients, is it weighted more towards bolus or more towards continuous infusion? So how many are more bolus? How many are more continuous infusion? So I have migrated my practice more, I would say, away from continuous infusion strategies and more towards bolus therapies. I was in Sydney for the INS meeting just a little bit ago and gave a similar talk on kind of the data surrounding bolus delivery of intrathecal medicines. And this isn't this presentation, but I can tell you that there is robust data that is continuing to grow describing the use of bolus therapy instead of continuous infusion when you're delivering the medication. And if we take a step back, I think it does make sense. So when we use a continuous infusion, what are we doing to those opiate receptors in the dorsal horn of the spinal cord? We're just bathing. We're bathing them over and over and over again. And I'm a huge proponent for trialing the medicine the way that you're going to continuously deliver it, or you're going to deliver the long-term chronic infusion. So if you're going to deliver the medicine intrathecally, trial intrathecally. I'm not an advocate for trialing epidurally or trialing systemically and then putting in a pump, because as we know, the pharmacokinetics of that is totally different. So as a corollary, the side effects are totally different. So I'm a proponent for, if you're going to deliver the medicine with a continuous infusion, you should deliver the medicine during the trial as a continuous infusion. If you're going to do the more bolus delivery strategy, you should deliver the trial as a bolus delivery strategy. And so there's been a lot of work surrounding this, and a lot of this, again, is on the shoulders of Christopher Bernard's and Tony Yaksh, so we'll review some slides associated with that. As Dr. Corner described, I've done a little work in the field, and I've really spent a lot of my time around education, and it came from a personal place where a family member required an advanced pain care therapy that wasn't implemented appropriately, and so the device didn't fail my family member, but the implementation of it did. So that's why I've spent a lot of time doing that. And as you can imagine, there are going to be on and off label discussions surrounding this talk. So a lot of intrathecal therapy, we have 2 FDA approved medications for pain, Infumorph and Ziconotide. And as an author of the Polyanalytic Consensus Conference, which is that living document, and we are planning on updating it here in the next 2 years. That was one of our meetings that we had at INS. A lot of the work that we do with intrathecal therapy is off-label because we use a lot of polypharmacy. So whether it's an opiate plus a local anesthetic, which is commonly bupivacaine, oftentimes you can add clonidine, but that medication selection is really married